Good morning, everyone, and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2024 Proposed Rules Part 2, Hospital, OPPS, and Medicare Physician Fee Schedule. PYA is happy to present today's webinar on this important topic. Before we get started, I'd like to go over a few housekeeping items. As this event is for CPE credit, there are some additional steps that we will take in order to comply with NASBA's requests. In accordance with NASBA, attendees will be provided 5 polling questions throughout today's presentation. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time in order to receive CPE credit for the presentation. If you encounter any issues responding to the polls, please send your answer in the question pane and we will document them for your CPE credit. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and the post-event survey must be submitted for proof of participation today. Credits will only be earned for sessions attended in their entirety. Please remember that this webinar is 1 hour and 1/2 of CPE credit. You may submit questions during the webinar by typing a message into the question pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to those questions posed after the webinar by email. We have posted handouts in the handout pane of the control panel. It is a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of this webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thanks, Laura. Good to be with you this morning and to actually have rules to talk about. When we met 2 weeks ago on July 12th, we thought we were going to have outpatient and physician rules, but of course they were released on July 13th. We were a day late or a day early.
Falling short, yeah.
Yeah, who knows? But I'm going to kick off today's meeting with a discussion of the calendar year 2024 Hospital Outpatient Prospective Payment System proposed rule. Recognize that the comments on this proposed rule are due on September 11th. And if I remember correctly, that is a Monday this year. Therefore, be thinking about this, folks. It's going to sneak up on you. So on the next slide, we kind of have an overview of the areas that we're going to talk about as it relates to the outpatient prospective payment system. As Laura mentioned, we're going to have some polling questions as a part of this as well. So you're going to get your first 2 polling questions as we go through the outpatient system. But let's go ahead and start with the payment update as proposed. We know that when we had the proposed rule as it relates to the inpatient prospective payment system for calendar year 2024, for fiscal year 2024, we were not pleased with the update as it was proposed. If that's the case from an inpatient perspective, it's going to be the same case for outpatient. There is a 2.8% increase that is proposed for outpatient services, but recognize that this is based upon older data than will actually be used in the final rule. I think whatever we see coming into play for the inpatient rule might be closer to what we get for outpatient, but this is the first area that I think you should focus comments on. What has happened in the care delivered in outpatient setting now in terms of the increase in costs, the costs of care, the cost of the drugs and supplies that are used and like that, to make sure that the payment rate is appropriate for the services that you are providing. So they calculated that 2.8% increase in the outpatient base rate at a market basket increase, saying overall costs have gone up 3%. However, they did reduce that by 0.2% for productivity. This is an ongoing adjustment that we have had to deal with for a number of years. And so it is that productivity adjustment that brings us back down again. Last time we met, we talked about the proposed rule related to the settlement for 340B and the underpayment for 340B providers, and that one of the provisions that would come into play in 2025 would be a further reduction of the market basket as more of a payback. Recognize this is where it would come in. It would be in the market basket of, let's say, 3% minus productivity minus that repayment amount for 340B. So whatever we get now, we want our market basket rate to be as high as possible so that when we start getting a greater reduction off of market basket, we are starting with a higher number. They are proposing a conversion factor of about 87.50. Currently, we're almost at $86. So this is still not a huge jump in the payment rates for your outpatient services. And finally, if you are a hospital paid under the outpatient prospective payment system that does not meet the quality reporting requirements, rather than getting a 2.8% update, it would be a 0.8% update, so a payment rate of $85.78. This is because the requirements, if you are not meeting quality reporting, essentially says that you would get market basket, the market basket minus productivity minus 2%. So that's where we come up with that 0.8%. We mentioned that we've already got a proposed rule on how to fix the 340B issue, but they are proposing for this upcoming calendar year to continue to pay all separately payable drugs, including those acquired under 340B, at average sales price plus 6%. So that is what was asked for under the under the litigation, and so that is where we continue to be. Currently, there is the opportunity for providers to identify those drugs that were excuse me, those drugs that were applied under 340B by using either the JG or the TB modifier. Beginning in January of 25, you would only use the TB modifier. If you're using JG now, you can go ahead and transition to TB. Forgive me, but as of January, they would 25, they would no longer accept JG. Drink of water, and then we'll go on to the next slide. Excuse me. All right, haven't talked this much. Under the Consolidated Appropriations Act of 2023, there was a provision that added a new level of outpatient mental health care, behavioral health care, for those patients who need 9 hours of intensive behavioral health services a week. Many providers currently offer partial hospitalization services, but the patients qualifying for that would need at least 20 hours of behavioral health services a week. This new program, less intensive than behavioral health, but an opportunity to really meet the needs of your patient population. There would be a requirement for physician certification and redetermination that the patient does qualify and meet the needs for intensive behavioral health. And these services could be provided in hospital outpatient departments, FQHCs, rural health centers, and community mental health centers. There would be 2 per diem rates established under this program, depending upon the level of care, the number of treatments per day that the patient was receiving. There would be 1 APC for 3 services a day, another APC for 4 or more services per day. Obviously, the 4 or more is going to have a greater reimbursement rate, a greater weight. And finally, they have also said that if this intensive behavioral health service is provided as a part of an opioid treatment program, there would be an add-on payment as well in addition to that base APC rate. So this is another area of comment that would be appropriate for a provider if you are looking at establishing such a program and you currently offer opioid treatments to address that requirement or that potential add-on for behavioral health services provided in an opioid treatment program setting and the additional payment. They did address payment for RHCs and FQHCs under this program, saying that rural health clinics would be paid at the outpatient PPS rate, whereas FQHCs would be paid the lesser of their charge or the OPPS rate. So this gives you the opportunity to evaluate the impact of such a program on your hospital. Excuse me, I'm sorry, Marty. With that, let's take a polling question.
Thank you. The first polling question is, does your facility expect to offer the Behavioral Health Intensive Outpatient Program? Yes, no, unsure, or I am not with a facility. Remember, you must fill out the polling question in order to receive CPE credit. You have 30 seconds to answer. Thank you for participating in our poll. Now I'll turn it back over to our presenters.
Unsure. Figured that was where we would wind up, but I definitely think that 20% who indicated that you would be providing this, I think is a great way to serve the patients within your community who don't need that partial, meet the standards for the partial hospitalization program. Let's look at site neutrality. This is one of the things that has been being discussed a lot in Congress. So that section of the proposed rule, we were very concerned about, were they going to come up with anything that would further impact your payment rates for off-campus departments? They did propose something, but what they proposed was a positive. And that was for those providers who offer intensive cardiac rehab programs in a non-grandfathered off-campus hospital outpatient department. This is one that wasn't in existence on November 2nd, 2015. Currently, you are paid at 40% of OPPS because CMS said 40% of OPPS equates to the physician fee schedule. Well, for cardiac rehab services, physicians are paid at 100% of OPPS. So for several years, providers offering off-campus, non-grandfathered facility cardiac rehab have actually been underpaid because they were paid OPPS minus 60%. So they are now saying off-campus, provider-based departments, whether or not you're grandfathered, you're going to be paid 100% of OPPS for this cardiac rehab services. This is an interesting scenario. And they have asked, are there other services that should be treated similarly, and have asked for comments about this. But I guess my question is, when is there going to be a group appeal about this cardiac rehab services that have been paid at 40% of OPPS and were to equate to physicians, but the physicians have been paid at 100% of OPPS? I think it's right for someone to pick up on this particular issue, and it might be worth a comment to say, are you going to go back and make us whole since this was reduced previously? Couldn't hurt to ask that question. For rural emergency hospitals, just a couple of clarifications that they did under the REH program, particularly related to Indian health services and tribal facilities. A lot of the IHS facilities have been hesitant to convert to a REH because they are not currently paid. They have no relationship to the OPPS program. Therefore, billing under OPPS would be confusing to those facilities. What they have said is that if an Indian health service or tribal facility chooses to convert to REH, you would be paid under your current all-inclusive rate program. plus receive that additional monthly REH facility payment. So it would be basically keeping the rate you have, but then also getting the monthly REH facility update. So this might help to encourage or address some of the IHS facilities that have been struggling to move forward with the REH program. And then they are moving forward with the adoption of an REH quality reporting program by proposing 4 new measures that would be reported on by REHs. A use of contrast material in an abdomen CT, median time from emergency department arrival to departure, facility 7-day risk standardized hospital visit rate after an outpatient colonoscopy, and the risk standardized hospital visits within 7 days after hospital outpatient surgery. Those measures are going to have to be tracked, particularly, I think the last 2 particularly, from are they going somewhere else? Because if you no longer have inpatient beds, is the patient coming back for outpatient care, or where are they going? So this becomes a question of where patients receive those subsequent services, I would think, Martie.
Yeah, and you know, it's interesting that this is what, out of all the issues they could address in OPPS around the REH program, this is what we get. You know, CMS is not formally publishing a list of hospitals that have converted, but we've been able to identify 4 since the beginning of the year, 2 down in Texas, 1 in Oklahoma, 1 in Michigan. So the progress has been slow here. And as hospitals are analyzing this opportunity, they're identifying a number of weaknesses in the program that really make it financially challenging. Some of those solutions may have to be legislative as opposed to regulatory, but hopefully this program will have a brighter future as it matures over the next several months, several years.
Thanks, Martie. Let's talk a little bit about ambulatory surgical center facilities. We know that the ASC update always is a part of the OPPS update rule. Again, we are looking at a 2.8% increase in the payment rate for these for the ambulatory surgical centers. And in the case of the ambulatory surgical centers, again, we're looking at market basket of 3% minus a 2.2 for productivity. But productivity adjustment was supposed to go away this year for ambulatory surgical centers. It was put in place under previous legislation to run from 2019 to 2023. CMS is saying we need additional information because during this period of time where we had the productivity adjustment for ASCs, we had COVID. We need more post-COVID data. They're going to continue that reduction then in the rate. Again, I'm not sure that this isn't a good area for comment. I think it would be something to say, should they really continue that productivity reduction until they get the data, or should they wait, get the data, pay us the full amount, and then decide what to do? But the ASC conversion factor is about $54, a little less than $54. And they are adding 26 dental procedures to the covered ASC procedures list. The reason for these additional dental procedures, and we're going to have some dental procedures added from the hospital perspective too, is the fact that there is expanded dental coverage under the Medicare program for certain services that would begin in calendar year 2024. From the quality reporting perspective for both hospitals and ambulatory surgical centers, we have 3 additional measures that we have 3 measures that are being modified. All of these to better either align with the CDC, standardized data collection, or to align with better clinical guidelines. So we have them listed on the slide. They are removing the left without being seen measure. That's been a tough one to address. And then they are adopting some new measures. The first 2 measures listed, the risk standardized patient reported outcomes following elective primary hip or total knee, as well as the hospital ASC facility volume for selected outpatient surgical procedures volume data. Those are both for ASCs and hospitals. The excessive radiation dose or inadequate image measure, that is only going to be for the hospital outpatient quality program. Now we get into the tough question, and we hope the voice holds up. Or I should punt and say I don't want to do this bad news. Here we go. We knew that something would be coming down the pike as it relates to price transparency. I actually thought it was going to be tied to the penalty rate and that they would increase the penalty adjustment for non-compliant hospitals. But that's not what they did. CMS is moving forward with proposing to modify standard charge to modify the display that you have posted on your websites to have a standard format. A matter of fact, just as to make it clear, there is a session this afternoon being offered by CMS that they will go through their standard charge formats and how they would like to see all charge information on that negotiated machine readable file, how they would like to see that posted. So interesting that that's today, but they are proposing to use standard charge display information. They are providing some definitions for like consumer friendly expected allowed charges, what is meant by the word encode, what is meant by a machine readable file. They would also be asking hospitals to confirm or affirm the accuracy and completeness of the data that they have posted in their machine readable file, and there would be penalties for inaccurate affirmation. They would be revising and expanding the information that would need to be included in the machine readable file. We've known this was an issue for a while, but making it very clear that providers would have to include both plan names and payer names so that it's not just saying Blue Cross, but it's all the various Blue Cross products, so that you have to be clear on that and clearly delineate those in your machine readable file. And you would also have to delineate your contracting method. Are you being paid on a DRG basis? Are you being paid on a per diem basis, a percent of charges, something like that? But you would have to clearly state out your payment method. And then the issues, additional information as it relates to the information provided on that spreadsheet on the machine readable file. All information as it relates to money would have to be provided in a dollar format, not a formula or a percentage. You can't say 90%, meaning they pay 90% of charges. You would have to say, you'd have to do the math. You would have to include a clear description of the service being provided, as well as identifying whether this was inpatient or outpatient. You can't use all the short little abbreviations that we use in our charge master. You need to make it consumer friendly. Sometimes when we actually go in and look at what people have posted, you really can't come up with it because you try and fit it in a certain space and it doesn't fit. So you shorten words. Well, no, you're not going to be able to do this. Again, consumer friendly description of your charges. The drug unit and type of measurement for any drugs that you are posting, and you would have to include any modifier, any billing modifiers, and then say what type of a code is this. I have used a code. I have put in a particular, let's say an evaluation and management level code. I would have to say that this is a CPT or a HCPCS code. And then I would also have to identify modifiers. That one really concerns me, and I think it is worth commenting on because you might do surgery on a toe, but there are 5 of them. And how are you are you going to have to price each one of those separately in terms of what you're posting in your charge master to include all the modifiers that could be used? So, and you get that with hands, you get that with feet, you get that with various services that you wind up having to repeat items in your charge master multiple times just to track all the modifiers. So concerning, I think, in terms of how that works. And you would have to maintain a text file and footer as specified by CMS. And because we do know that there have been some concerns that the files that have been posted really do not allow someone to search to try and find that. All of these changes would be required by March 1, 2024. We aren't going to get a final rule until November. And then you got to make these changes. And I think this is, again, worthy of comment. Can you become compliant and make the required changes in 3 months, essentially? I'm going to knock out November and December. It doesn't give you a lot of time to make changes. So
I think, Kathy, with all the legislation that's being tossed around in Congress,
right,
which will go even further in imposing additional requirements, how are we going to square all that up?
Well, and I'll raise the one, Martie, that has me most concerned, and that is the requirement for all of your outpatient departments to have their own NPI. And that's passed through several committees, and not just pay, the most recent one was for not just for billing Medicare purposes, but for billing commercial insurance. So my concern there, if all of a sudden I have a different NPI for this particular outpatient department, does that mean I need another price transparency file posted?
Right. Well, all this legislation is passing, such as that provision, it's passing unanimously.
Exactly.
In the House. And we're about to hit August recess, so things will calm down, but September is going to be a mad dash because we've got to get all the appropriations bills done by the end of September, or that provision of the debt ceiling limit legislation, that if you don't get all the bills done, it kicks in another sequestration. So it's going to be a busy September.
Would be depressing.
Yeah, exactly.
One more slide on price transparency. And this is information that we've kind of seen from CMS in some notices that they've published lately, but they would be updating the enforcement provisions using various methods to assess your compliance. Essentially, they want to develop tools for CMS themselves and their contractors to assess your compliance. You've attested based upon this proposed rule that you're compliant. Now they want to go in and verify that. They would want you, if you received a warning notice that you are not compliant, that you would acknowledge the receipt of that. And then also, if you are a part of a hospital system, they would be reaching out at a systems level to figure out why, or to address why some hospitals within your system are compliant and others aren't. Is it an issue of certain providers are perhaps in greater competition with other facilities, and then you've got some smaller hospitals who are kind of standalone, don't have that level of competition, so I post their rates, but I don't post the big guy. So it's going to be interesting to see how that impacts from a systems level. When we've looked at the data that's posted at a systems level, we do find instances where larger facilities within a system have not posted where the smaller facilities have. And then CMS is going to be more focused on publicizing their enforcement activities as it relates to the hospitals that are non-compliant. Any penalties that are assessed, any errors that are identified, etc. And then I think this one is very interesting because having tried to find hospitals' websites, but it would require that you have a footer on your homepage that links to the page containing your machine readable file. Essentially one click, as opposed to the 2 clicks that they gave us earlier on. So now let's look at another polling question.
Thank you. The second polling question is your hospital currently compliant with existing price transparency rules? Yes, no, unsure, or my organization is not a hospital. Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer.
I think I know what the answer is going to be.
Thank you for participating in our poll. Now I'll hand it back over to our presenters.
That's not what I expected. I thought there would be more unsures. And the reason I'm going to say that is because it seems like every time you turn around, there's a report coming out that you thought you were compliant and someone else is saying you're not. So I'm glad that there are this many hospitals that are confident that they are compliant. So yay, that's what I'd like to see. Before I turn it over to Martie, just a couple of more slides related on other issues to wrap up the OPPS proposed rule. There are no additional services that they are proposing that would require prior authorization. We stick with, I believe it is the current 5. They are not proposing any deletions from the inpatient only list, but this is interesting. They are proposing to add 9 services, but those 9 services are only described by these placeholder CPT codes. We don't really know what they are. It's just, here's a code. And we want to hold these on inpatient only. So we're going to see as we get to final rule or more information what those placeholder codes actually apply to. But they are also requesting comment on removal of certain gastric restrictive procedures off of the inpatient only list. So that would be removing certain procedures from inpatient only, allowing them to be done on an outpatient basis, and then likely after a period of time to be performed in an ambulatory surgical center. So if you do provide those services, it might be worth comment. They are proposing 2 new comprehensive APCs. Basically, the first one that's being proposed would be an intraocular APC that they are splitting the current one into 2, and then a new APC for a level 2 abdominal and other related procedures. So again, something to take a look at because of the comprehensive APCs and the bundling of the other services related to that care. And last but not least, under the other issues, they are requesting comments on the bundling policy for diagnostic radiopharmaceuticals. How should this continue to be done, or should it be done? They are looking from a packaging perspective to continue, to raise the packaging threshold to $140 a day. But this is a very interesting issue on the bundling policy for the diagnostic radiopharmaceuticals and determining whether or not they should continue to be bundled in with the service provided or if they should be separately paid. What evaluations for health equity should be included in outpatient services? Again, putting that focus on health equity and how should we evaluate the hospitals and the ambulatory surgical centers for their meeting the needs of their patient population. And then there is this discussion of how can they provide, how to identify and how to provide additional payments to those hospitals that maintain access to essential medications in the time of a public health emergency or another major emergency situation. And that if you are stockpiling or storing, I don't like stockpiling, if you are storing these essential medications and having to constantly rotate stock, et cetera, but to be able to better meet the needs of your community, should you be receiving some additional payments for that? Because you go into a wastage issue, they are never used. Should there be any reimbursement for you? So it's an interesting concept. I think it's one well worth tackling, particularly in areas where you run into hopefully we're not going to have another COVID public health emergency, but where you have major issues related to weather conditions, things like that, if you are storing meds to help others within your community, should you receive additional payment for that? So with that, it is physician time. It's Martie time.
Oh, great. And gentle reminder, dear friends, that this webinar is scheduled for 90 minutes. That's why you get 1.5 CPE credits and why we have 5 polling questions. So I'll have the last 3 polling questions as part of this presentation. So we are going to spend a little under an hour talking really at the overview level of the Medicare physician fee schedule proposed rule. As Kathy noted, the 2 rules came out on July 13, and our comments for both are due on September 11th. Here, we're going to do a baker's dozen, review 13 different topics of interest within the Medicare physician fee schedule. This is a monster of a proposed rule. The public inspection copy, which of course is double-spaced, weighs in at 2,033 pages. In addition, when you go on the CMS physician fee schedule website, there are 23 separate downloads that also relate to provisions in the fee schedule, everything from RVU weights to the telehealth list, to the care managers list, to misvalued code lists. All that is not published as part of the Federal Register, but instead maintained on the CMS physician fee schedule webpage. The big headline, what you've been seeing since the publication of the proposed rule, is the cut. That CMS is proposing a 3.34% reduction to physician payments. And certainly that is significant, that is concerning. But to be an effective advocate for the outcome to be different than that at the end, you really have to understand how you get to 3.34% cut. Because it's a matter of, yes, the pie is shrinking slightly, but the pie is being redistributed. And that creates our favorite challenge, winners and losers, and how we balance the interests of those winners and losers in coming up with a solution. So we're going to take the first 2 topics, the conversion factor and the office outpatient E&M visit complexity add-on code, because that's directly relevant to how we ended up where we are with this proposed reduction. So let's go back to the basics. And how do you calculate a fee schedule payment? This is very different than all of the prospective payment systems, because those systems have built into them a vehicle for addressing inflation year over year. That's the market basket update that Kathy talked about in OPPS. That's how we evaluate, oh, there's been changes in costs, and thus we need to adjust payments accordingly. There are a formula built into the statutory schemes and the regulations to do so. We don't have that with the Medicare physician fee schedule. So we start with a very simple formula. We assign to each service a relative value unit. In fact, 3 different types of relative value units: work, practice expense, and malpractice expense. Those 3 added together equal the total RVUs for the service. And then we have something called a conversion factor. And a conversion factor is a dollar figure. And the conversion factor is multiplied by the number of RVUs, and that gives you the national payment rate for that particular service. So how do you determine what the conversion factor is? Well, there is a dollar amount available for Medicare physician fee schedule payments. That is statutory. Congress put a cap on how much CMS can spend, how much it can pay in reimbursement under the Medicare physician fee schedule. We used to have, again, a formula called the sustainable growth rate, but we replaced that in 2015 with the macro annual adjustment factor. And for the years 2020 through 2025, there is a 0 adjustment factor in effect under that statute. So the dollars available to pay under the Medicare physician fee schedule would stay constant, absent any other action. So if you increase the number of RVUs or decrease the number of RVUs, that requires you to adjust the conversion factor. And in fact, the statute requires that if CMS proposes to increase the number of RVUs or decrease the number of RVUs by more than 20 million, that would necessitate an adjustment to the conversion factor. So if I go from 100, if I estimate that 100 RVUs are going to be provided, and I only have $100, then I know each RVU is going to be worth $1. But if I increase the number of RVUs to 110 and still only have $1 available to distribute, I'm clearly going to assign a lower value to each RVU, i.e. my conversion factor is going to go down. So this is how we do budget neutrality within the physician fee schedule. And then again, the additional adjustment based on your geography, to reflect variation in practice costs between metropolitan and non-metropolitan areas. We have a specific adjustment factor based on region, which are assigned to each MSA and then each non-MSA area of the state. So if the average is 1, if your costs are less expensive, that adjustment's going to be lower than 1. If your costs are above average, they're going to be higher than 1. So we've had quite a journey over the last 4 years, or 5 years now, with the conversion factor. Start back in 2019, when macro was still working the way it was supposed to work. We had a conversion factor of 3604 that increased slightly for 2020 to 3609. And then in 2021, CMS comes out and says, we're proposing a conversion factor of $32.26. And everyone's like, what? Why such a significant adjustment? And that was driven by the fact that CMS was introducing changes to the RVUs assigned to outpatient E&M services. And in addition, CMS was proposing to introduce an office outpatient evaluation and management complexity add-on code. This was intended to add additional reimbursement, primarily for primary care providers, as well as the medicine-based specialists. So for each time they build an E&M service, they would be able to include this add-on code, which is intended to compensate for the additional work of providing ongoing care for a patient. And when you took the number of RVUs, additional RVUs, that new code would generate, plus the RVU adjustments for the E&M adjustments, that resulted in a budget neutrality hit of a little under $4. Well, then that was obviously, very significant and impactful, and especially during the middle of a pandemic. So in December of 2020, in the Consolidated Appropriations Act of 2021, Congress stepped in and provided a rate increase, which brought the conversion factor up to 34.89 for 2021. In 2022, we saw the adjustment, we saw the adjustment to 33.59. So again, we went down more in the proposed rule. But then Congress again stepped in and brought it back up to 34.61 in the Protecting Medicare and American Farmers from Sequestration Cuts Act. That one was off the tongue, doesn't it? That legislation provided a one-time 3% increase for 2022. That gets us to the proposed 2023 rate, which was 33.08. Again, Congress, because of adjustments to RVUs, Congress in the Consolidated Appropriations Act of 2023 steps in again with a one-time increase that gets the rate for this year to 33.89. So you see the pattern now. It's Congress does what it's supposed to do in terms of the RVU adjustments. Congress comes in and makes an adjustment. And so we've seen this pattern now over the last several years. So for 2024, the proposed conversion factor is 32.75. That's a decrease of $1.14 or 3.34% compared to the current conversion factor. How did we get there? Two things at play. First, the Consolidated Appropriations Act of 2023 that increased the rate for 2023 mandated that there would be a 1.25% reduction for 2024. So 42 cents of that cut, Congress approved last year. They said, we'll increase you this much this year, but only that much next year. And so we're now in next year, we're only getting that much, which is 42 cents less. The remaining reduction of $1.14 is due to the budget neutrality adjustment, which comes in at about 2.2%, and that accounts for the additional dollars. That budget neutrality adjustment, CMS tells us that 90% of it is attributable to the new reimbursement that it proposes for outpatient, office outpatient, E&M complexity add-on codes. And then 10% is attributable to all other new reimbursement and valuation changes on the fee schedule. So yeah, Kathy, please.
I was going to say, so the 90% attributed to new reimbursement for the office outpatient, the
add-on code. We're going to call it the add-on code from here out.
The add-on code. Okay, what we suddenly are dealing with is now we're pitting docs against docs.
We are, and it'll be interesting to see how this plays out in the comment period, and then if we need to pursue a congressional solution.
And how we can get a congressional solution this year, particularly to something that just a year ago, they said we're going to do this reduction.
Right. So this really does come down to add-on code or no add-on code, or a significant restructuring of the add-on code.
Or it comes down to politics.
Yeah, it comes down to politics. But yeah, last year
it's not going to be addressed through comments. I mean, you can comment and you need to comment, but CMS's hands are tied unless Congress acts.
Well, unless they choose not to include the add-on code. They could strip the add-on code out.
Yeah, good point.
And that's the debate, I think, we'll talk about this as we start talking about the add-on code, the impact, the redistributive impact it has of the fee schedule pie. Okay, so let's talk about the add-on code.
Sorry.
This is not new. We've been down this road before. G2211 was originally proposed by CMS back in 2021. And that was that huge cut that had been proposed, and then Congress swept in and said, no, here, this should be the conversion factor. As part of that, Congress said, CMS, you cannot reimburse G2211 until, wait for it, January 1st of 2024. So this is the first opportunity CMS has had since that Congress said, no, you can't include that for this year. You're not going to reimburse into the fee schedule for that new code. Not until January 1st, 2024. So this should come to a surprise as no one that CMS has once again included this add-on code and the impact it has on the conversion factor. You see there on the screen the official definition of the add-on code, but it's intended, again, for the extra work practice incurs, because it's providing ongoing management for patients. It's the complexity of providing ongoing management, not necessarily the complexity of the patient's condition that's driving the reimbursement here. What we did get in the proposed rule is some explanation of the billing rules around this. And the reason they got to the billing rules is because they significantly adjusted their projections on how often this code would be billed. So back in 2021, when they were proposing this the first time around, their assumption was that this code would be added to 90% of office outpatient E&M codes. So they expected everyone to be using this aggressively, and that's how you got a $3.3 billion spending impact by including this as reimbursement. So in this go around, CMS wants to get that 90% down. And in doing so, it starts making, okay, it's not billable here, but it is billable here. And the first one they say very clearly is you can't include the modifier, you can't include the add-on code when you have the payment modifier 25. So that is cut out. Then they get into a more subjective standard, which is if the care is being delivered by a practitioner who does not intend to have a longitudinal relationship with the patient, then it's not appropriate to bill the code because there's not that added complexity involved. And the example they give are like urgent care clinics, consults, second opinions. So it's a one-stop, one-hit patient visit. In those instances, it would not be appropriate to bill the code. There are no documentation guidelines handed to us. We don't know what needs to be included in the record. We don't know and this is a code you can bill for both new and established patients. So if you have a new patient, you assume to have a continuing ongoing relationship with them, it'd be appropriate to bill the code for that visit as well. So this was, and certainly CMS received commentary back in 2021 from the professional societies that there would need to be an opportunity to educate their providers about how this code operates and what documentation is necessary and how we build systems. But none of that is addressed in detail here in the proposed rule. So this code is assigned just shy of a half RVU. So the payment amount is about $16. So we're adding that on to all of these E&M codes. Bottom lines, for purposes of the budget neutrality calculation, CMS assumes that the add-on code will be billed with 38% of all OOEM services in 2024, expecting that to eventually increase to 54% as we get used to billing the code. But for purposes of the conversion factor math, what matters is that 38%. So for 38% of E&M codes, we're adding $16 in additional reimbursement. That gets you to that increase, that impact on the conversion factor. Every year, CMS includes with its proposed and final rules the tables that show the redistributive effect of the policy decisions included in the rule, and it does it by specialty. So it provides a very broad picture of what's the impact on allowable charges by specialty. And it's not intended in any way, shape, or form to be an individual provider can expect this much of an increase or that much of a decrease. It's instead overall for the entire specialty, what do we anticipate the impact will be? No surprise, Table 104 of this year shows that primary care plus the medicine-based specialists, rheumatologists, endocrinologists, and the like, they will see between a 0 and 3% increase in their allowed charges. Specifically, family practice and endocrinology are on the high end of that at 3%. Most of the specialties are sitting at 2, a few at 1, very few actually at 0. On the other side of the aisle, the proceduralists plus emergency medicine, they're going to be looking at a 0 to 4% decrease in allowed charges. Specifically, nuclear medicine, radiology, and vascular surgery are at -3, and interventional radiology is the -4. Again, most are at -2, -1. But obviously, significant redistributive effect. If we're going to pay more for primary care, because the pie is only so big, that means we're going to be paying less for the work that our proceduralists do. So you're right, Kathy, this sets up a really interesting commentary. At this point, everyone's saying, Congress fix it, just give us more money, Congress fix it. They're not specifically targeting in on how CMS, the policy provisions that resulted in the calculation of the conversion factor. But it is clear CMS's intention is to improve reimbursement for primary care, but their only tool to do that is to reduce the conversion factor for everyone else.
Well, what scares me is they're asking Congress to do something, and I see so much media discussion related to we need a new system, a totally new system.
Yes.
That's scary.
Yeah, and I've seen some that say that we just need congressional funding for the add-on code. So we need to increase the size of the pie just by the add-on.
And that might be something to address with your legislators.
Right.
Okay, as opposed to the issue of give us a whole new system. That could be scary right now.
Right. It's one thing just to have your hand out, but it's a very different story to say we've historically underpaid primary care. This is a system intended to address that, but we don't need to do that on the back of our other physicians. We need to do that with additional new dollars into the system, and it's a couple $1 billion. So it's not, famous words, a million here and a billion there. All of a sudden you're talking real money, right? But it's going to be a very interesting debate on this going forward. And I have absolutely no bets on I guess that's where we get to a polling question, because I'm going to ask you what your bets are on what Congress is going to do. So Laura?
Thank you. The third polling question is, do you think Congress will take some action to lessen the proposed reduction in the conversion factor for 2024? Yes, no, or unsure. Remember, you must fill out this polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
Oh my goodness. Those are interesting results. We have almost an even split among our attendees. I go in the category of I never try to predict what Congress is going to do. So I think I'll put myself at unsure. What do you think, Kathy?
Unmute. I agree with the unsure. And no matter which one, fearful. That should have been the third question, a fourth one.
Yeah, and part of this is we don't know till the end, because the Consolidated Appropriations Act, which apparently is what we now call the vehicle bill, they don't tend to show up until December. So like we often have the proposed rule, the final rule, and then we get the congressional action, and CMS has to come back in and adjust the conversion.
And then we go with a period of time where claims are underpaid. Let's assume that they fix something to pay, higher. They're going to be underpaid for a period of time.
Right.
And then they're going to readjust those claims.
Right, exactly. So after that not so pleasant news, I'm going to give you two good pieces of news. The first, which there was much rejoicing, CMS decided that its changes to the split shared visit rules, which would require that the determination of substantive portion of the service would be based on time exclusively. They had last year delayed its implementation by a year. They are again delaying implementation, permitting you to continue to determine substantive portion of split shared visits based on history, physical exam, medical decision making. This will afford CMS says this affords providers another opportunity to comment on the time only rule. So I think we've got our hands around the neck of this very not well received, there we go, change to split shared visits. And it's certainly an opportunity, if this impacts you, to be commenting about the challenges this creates. Certainly, we appreciate that in many instances, this is going to lead to reduced reimbursement, as services will end up being billed under the non-physician practitioner MPI as opposed to the physician MPI, resulting in that decrease in reimbursement, that 50% cut, but also just plays haywire with any WRVU compensation-driven models, how you're going to count that for determining how to pay your physicians under your comp model. The other good news is the death knell of the appropriate use criteria program. This puppy was mandated by Congress back in 2014, and they directed CMS to figure out a way to require practitioners who were ordering advanced diagnostic imaging services to consult a qualified decision support mechanism, i.e. make sure that you really need to order this test and there isn't something else you should be doing first. CMS has tried to implement these rules. They even wrote regulations, but they are concerned about how implementation will move forward, so they are deciding to pause their efforts for the program for reevaluation, and in fact go so far as to rescind the program regulations they had promised previously. So hopefully next year we won't have to talk about AUC, and it will be officially a thing of the past. Yeah. Unless Congress comes back and said, no, we really, really meant it. But again, this is 9-year-old thinking about how we're going to control costs for
Well, and all
diagnostic
it did
imaging
was
tests.
create burden on those who were reporting, and again, did not do much to address those individuals who were prescribing inappropriately.
Correct, correct. Let's talk more new money. These are 3 new codes that CMS, well, it's actually a set of 5 codes, but 3 different types of services that CMS proposes to begin providing reimbursement in 2024. All of these are related to addressing health-related social needs. So we have social determinant of health risk assessment, community health integration, or CHI, or principal illness navigation, or PIN. So you know, you've spent good time today, you have new acronyms right there. Okay, so let's talk with the social determinants of health, or SDOH, sorry, I'll just talk in the acronym, risk assessments. This is reimbursement on the physician fee schedule for the administration of a standardized evidence-based risk assessment tool requiring 5 to 15 minutes, which can occur no more often than once every 6 months. The assessment must be performed on the same day that the billing practitioner performs an evaluation and management service. It can be completed by auxiliary personnel so long as you meet the incident 2 requirements, the direct supervision requirement. CMS did add this code to the Medicare telehealth services list, meaning that it can now be performed not in person, but utilizing audiovisual connectivity. With regard to what constitutes a standardized evidence-based risk assessment tool, they identified 3 in the proposed rule. The CMS Accountable Health Communities tool, which is probably the one in the broadest use right now. The PREPARE tool, it's an acronym, I'm not exactly sure what it stands for. And then instruments that have been used in the special needs programs for MA. When you use the tool, what needs to be in the record then are the identified needs. So if you complete the assessment, you would document the identified social needs for that individual. CMS encourages you to do that by Z code, to use those Z codes to describe those conditions, though they do not require it. CMS then is seeking comment to see, should we add additional requirements for this risk assessment reimbursement, because we want it to be medically necessary. So is the practitioner, by submitting a claim for this service, also thus representing that they have the capacity to do something about it? Do they provide care management services, or do they have a partnership with a community-based organization that will help address the identified SDOHs? Our reason to do the assessment is not just to have the information. It's in fact to have information that we can then take action on. CMS also says, how would you typically think, also seeks comment on how do you think you typically provide these services, and who would typically be involved in providing this information? The payment rates they propose are just short of $19 in the physician office setting. For the facility setting, it's a little under $9, but appreciate it's tied to an APC, separately chargeable for the hospital overhead expense, and that's paying out at just short of $29. So in the hospital outpatient setting, it's getting closer to $40 for doing this 5 to 15 minute service. Then we have community health integration, or CHI. This is tied to an initiating visit. So there has to be before you can bill for CHI, you have to have a CHI initiating visit. That has to be an evaluation and management visit where the billing practitioner identifies the presence of social determinants of health that limit the practitioner's ability to diagnose or treat the problems addressed in the visit. That CHI initiating visit is separately billable, but it's effectively the medical necessity that drives the CHI services. So it's the physician sees the patient, says, there's something going on here. They have transportation issues, they have housing instability, and that's certainly going to impact my ability to manage their diabetes appropriately. And so I'm going to order CHI services for this patient. CHI services then are performed by certified or trained auxiliary personnel under the general supervision of the billing practitioner. And you see there the reimbursed, you see that the first code, the GXXX1 is for 60 minutes per calendar month, with the add-on code 30 minutes every calendar month. So first of all, let's talk about who are certified or trained auxiliary personnel. CMS is looking here to community health workers, to patient navigators, to individuals, not social workers who are not LSCSWs, they just have maybe undergrad training or the like. The training then is for an individual to be qualified to provide this service. They either have to hold a certification, a relevant certification, or they had to receive training. You see there in the second bullet what CMS expects of such training for individuals who could perform these services. And then that third bullet is the language from the description of the code and the types of work that would be involved in community health integration. As you'll note when you read this later, because you don't want to read it while it's on the screen, it's non-clinical work. It's really coordination of services. It's providing some health education resources to patients. It's facilitating services for patients. It's basically being a shoulder to cry on, though they don't actually use that language. But those are the types of services, what you would expect really as we kind of define the role of community health worker. That's what this is intended to provide reimbursement for. There are a lot of state Medicaid programs that have created a reimbursement for community health workers. This is CMS now bringing that up into the Medicare program. And in fact, one of the comments they request on this is, how does this align with your state Medicaid programs? More details. The auxiliary personnel must document their activities, including the amount of time they spend in the billing practitioner's EHR. They need to include the relationship of the activities to the identified SDOHs. CMS does not intend, unlike the other care management services where we have to get consent from the beneficiary for those services, CMS is not proposing to require consent for this service because they assume this is largely going to be provided face-to-face. It doesn't require that it be face-to-face, and certainly some of this is going to occur telephonically, you would expect, but they're saying we just don't think it's necessary for this type of service to provide consent. They note that only one practitioner can bill for these services in a given month. It can be billed in the same month as other care management services like CCM or RPM, just no double counting of time. The billing practitioner can arrange to have these services furnished to a third party, such as a community-based organization, provided there is sufficient clinical integration between the third party and the billing practitioner. Again, that's language very similar to what CMS has said previously about care management. Then you see there the payment rates for these services. Significantly, for the 60 minutes of services, it's about $79 in the facility setting. Lower in in the non-facility setting, it's about $79. Again, lower in the facility setting, but also tied to an APC, which is going to give you $87 of reimbursement. And then, of course, the lower amount for the add-on code. The other development here with CHI is that CMS is adding CHI to the list of RHC, FQHC care management services that are billable under G0511. Next up is PIN, Principal Illness Navigation, intended for patients who have been diagnosed with a serious high-risk disease. CMS clarifies that it's a condition that's expected to last at least 3 months and places the patient at significant risk of hospitalization or other institutional care. It requires for that patient the development or monitoring or revision of a disease-specific care plan by the billing practitioner, which may require frequent adjustments of medications and the like. The examples that CMS provide of such conditions include cancer, congestive heart failure, chronic pulmonary disease, HIV/AIDS, severe mental illness, and substance use disorder. Again, like CHI, PIN has an initiating visit where the practitioner determines that PIN services are necessary and they establish an appropriate treatment plan. The PIN services are then performed again by certified or trained auxiliary personnel under the general supervision of the billing practitioner. Again, a code for 60 minutes with a 30-minute add-on. The level of training for the auxiliary personnel, similar to what we talked about with CHI. And then look at, again, the list of services that you would expect to be delivered as part of PIN. Again, very focused on helping the patient adjust and manage their condition, as well as their continual interactions with the healthcare system going forward. A lot of these PIN details are going to look very familiar because they're very similar to CHI. The documentation by auxiliary personnel in the medical record, not requiring consent because, again, this assumption is primarily going to be in person. Only one practitioner can bill per month, though you can still provide care management services at the same time. And then you can have an arrangement with third party. These are so similar that the payment rates are the same for the two codes. And again, it is also added to the list of care management services for RHCs and FQHCs. So that gets us to polling question number 4.
Thank you. The fourth polling question is your organization likely to consider providing CHI and/or PIN services? Please select 1. Yes, no, or my organization does not bill under MPFS. Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
Oh, that's great news. We already have half of our attendees seriously looking at providing these services. And you're already dealing with, social determinants of health for your patients, and you're trying to manage those conditions, and certainly deserve to be capturing the reimbursement to support that work.
Interesting response.
Yeah, that's great. Okay, let's talk telehealth. CMS in the proposed rule is aligning its telehealth policies with the telehealth extensions that were included in the Consolidated Appropriations Act. You know that at the end of 2024 that the waiver of the geographic location requirements for Medicare telehealth reimbursement have been waived. The delay of the in-person requirement for telebehavioral health services, the continuation of reimbursement for RHCs and FQHCs that provide telehealth services, an expanded list of telehealth practitioners. That's how we got our PT, OT, speech language pathologists now can provide telehealth. We're going to add to that list marriage and family therapists as well as mental health counselors for 2024, and continued coverage for audio only services. So just square up policy and align it. Very interesting action CMS proposes to take with respect to the telehealth services list. Remember, it's about 100 listed services pre-PHE. It expanded out to about 250 during the PHE. CMS's solution, as it discussed this issue during the course of the PHE, was, well, we're going to move some of these codes to Category 3 because we think we want more information, and so we want to continue providing those telehealth for a certain period of time. CMS has said enough of this Category 1, 2, and 3. It confuses everybody. We're going to have permanent and provisional. And permanent means it's met the criteria to be a telehealth service, and provisional means it's getting there, and we're going to continue to watch the evidence, and we may or may not remove it in the future. On that, it appears when you compare the 2023 telehealth list with the proposed list that's included in those downloads on the physician fee schedule webpage, it appears they're moving all of the pandemic recognized telehealth services to provisional, not just the Category 3 codes, because the number of services is the same. So this is great news, and there's no time frame provided in the rule for removing provisional codes from the list. It's not like you get 2 years and then you're off. It's sort of, you're on the provisional list, we're going to reimburse you for this service, but we may take it off at some future point in time if the evidence does not support it. So this is very comfortable that we're going to basically maintain the same types of service being available via telehealth under the fee schedule. The billing and payment rules, however, will change at the beginning of the year. You will begin using Place of Service 2 for telehealth provided in a location other than the patient's home, and POS 10 for telehealth provided in the patient's home. So no more 95 modifier, no more using the place of service as if the patient had received the services in person. The other change, so that's how the coding changes, the payment changes, that if you list POS 2, you're going to be paid at the non-facility rate. So if you're a physician practice, you bill non-facility, you're going to get paid at that higher rate. If, however, it's telehealth services with POS 10, then it's going to be paid at the lower facility. So there is a change there. Remember, during the PHE, everything was paid at the non-facility rate. This is the change that they're proposing going forward. They intend to suspend the frequency limitations for certain visits and the use of telehealth for those visits. They propose to continue to permit teaching physicians to have virtual presence when a service is provided via telehealth. So if it's a three-way telehealth visit, that is appropriate, and they'll continue to, that level of supervision would be appropriate. They intend to eliminate the in-person requirement for injection training under the Diabetes Self-Management Training Program. They intend to continue to permit opioid treatment programs to furnish periodic assessments via audio only through the end of 2024. And then of note that for 2024, the originating site facility fee will go up to $29.92 next year. It is one of those things that is tied to inflation. It's tied to the medical economic index. Big change, and Kathy and I couldn't decide who was going to talk about it, but I won, is telehealth services furnished by institutional staff. So for certain types of services furnished in the hospital outpatient setting, specifically outpatient therapy, diabetes self-management training, and medical nutrition therapy, the hospital is reimbursed on the Medicare physician fee schedule rate. In fact, any institution that provides those services are paid at the Medicare physician fee schedule rate. During the PHE, we allowed an institution, a hospital, to receive reimbursement for these services when they were performed by staff for patients in their homes. This is part of that Hospital Without Walls initiative during the PHE. When CMS was doing its PHE unwind guidance, it said that reimbursement will no longer be available. So that's going to be gone. Now they're coming back and saying, we need to ensure access to services. So we propose to extend such reimbursement through the end of 2024. So for these types of services, if it's hospital staff performing the service, and they're not otherwise reimbursed for that service, it's in fact the hospital being paid for the hospital staff's work, then that's going to permit this continued reimbursement for telehealth furnished in the patient's home. Finally, on the topic of telehealth, is what?
Important to comment on that one.
Yes, very much so, very much so. Direct supervision. We know during the pandemic, we were excused from the traditional incident 2 rules, which required that a physician be physically present in the same suite of offices and immediately available to provide service, to having what we refer to as virtual direct supervision, the availability by an audio-visual connection. CMS had said last year it would extend that rule to the end of 2023, and now they're saying let's extend it another year to 2024. Thank goodness. So another reprieve on going back to the personal presence requirement for direct supervision. It's just audio-visual connection. And CMS is soliciting comment to extend the definition of direct supervision permanently to include virtual presence. They specifically are looking for comment on the impact on patient safety and any quality concerns. So on that note, let's go to our 5th and final polling question.
Thank you. The 5th and final polling question is, do you believe CMS should make virtual direct supervision permanent? Yes, no, or you're unsure. Remember, you must fill out this polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our polls. I'll hand it back over to Martie.
Interesting. I thought this would be 100% yes, but we certainly have some differing opinion on this. So either way, it's a great opportunity for comment going forward. Okay, whoops, skip one. Remote monitoring, a topic near and dear to my heart. CMS provides reimbursement for remote physiologic monitoring and remote therapeutic monitoring. And we have struggled to figure out the rules of the road. So here's the guidance we received in the proposed rule. This is what's new with regard to remote monitoring. Great news for our rural providers and our federally qualified health centers. They are adding RPM and RTM codes to the list of care management services for which they can receive reimbursement. The exception, interestingly, is there will be no reimbursement for the codes that correspond to initiation and setup. So like for RPM, that's 99453, that is not included. So there will not be reimbursement for those services, but monthly monitoring, treatment management services, there's now reimbursement. There will propose to be reimbursement for RHCs and FQHCs. CMS intends to revise the regulations to permit Medicare enrolled physical therapists and occupational therapists to bill for remote therapeutic monitoring services that are furnished by PTAs and OTAs under general supervision. Rule had been and that really been much more restrictive previously. This is intended to expand the utilization of RTM services, and CMS is seeking comment on whether general supervision of PTAs and OTAs should be extended to other services beyond just RTM. CMS clarifies that RPM and RTM may be furnished to patients within a global surgical period so long as the condition being monitored is unrelated to the surgery being performed and you are addressing an episode of care distinct from the surgical episode. It notes that the established patient requirement is again in effect post-PHE for remote physiologic monitoring. This begs the question, and CMS needs to address this one because it creates all sorts of confusion. Is there no established patient requirement for remote therapeutic monitoring? And in fact, the code was created during the PHE when the established patient rule was waived for RPM, but CMS intend not to require an established patient relationship for RTM. There's also a very extensive request for information on digital therapies and remote monitoring. CMS wants your commentary to help them identify challenges and take advantage of opportunities to improve coverage and reimbursement and payment policies. We've also got some repeats in the guidance that CMS has provided with regard to RPM. They note that RPM and RTM codes require data collection for at least 16 days of data in a 30-day period. But interestingly, in the codes they list that require 16 days of data, they do not include the RTM setup and patient education code. They do include the RPM one, but not the RTM one. They note that only one practitioner can bill for the 99453 and 54, or the codes that correspond to the RTM services. Again, interestingly, this list does not include RPM treatment management services. So can that be billed by more than one practitioner? A practitioner cannot bill RTM or RPM services in the same time period, but they can bill for other care management services at the same time. But can one practitioner bill for RPM and another bill for RTM? I don't think that's addressed squarely by CMS either, otherwise. And then CMS does clarify again that services associated with all medical devices can be billed once per patient per time period. So even if you're providing a blood pressure cuff and a medical weight scale and a glucometer, there's only one unit of monitoring that can be billed, and not one for each device provided to the individual. Another new benefit that CMS proposes to add are caregiver training services. And this is when the treating practitioner believes that caregiver involvement is critical to a successful outcome. And they provide training based on the patient's treatment plan to the family. There are two codes here, two sets of codes here. The first 96202 is caregiver behavior management services. Your intended here to train multiple individuals at the same time, and you bill once per beneficiary. There's an initial 60-minute code and then a 15-minute add-on code. The valuation for this code, you see pretty low payment rates, but the valuation on the code assumes that there are 6 beneficiaries, caregivers participating at any given point in time. So you're going to have a classroom of individuals, and that's going to represent at least 6 beneficiaries for whom you can submit a claim. That's certainly an opportunity for comment based on those folks that have been doing caregiver training, if that's a reasonable assumption. The other training concerns when the patient is under a therapy plan of care, you see the codes there. You see the codes that can be built for that. On behavioral health services, CMS is implementing several provisions of the Consolidated Appropriations Act of 2023, particularly the addition of marriage and family therapists and mental health counselors, who will then be able to bill at 75% of the psychologist rate. They'll be allowed to enroll the program after the publication of the final rule. They've also been added to the list of RHC and FQHC practitioners. They are creating the reimbursement for psychotherapy for crisis services as required under the CAA 2.3. They are expanding the number of types of providers who can furnish health and behavioral health assessments and interventions. They've begun the first of a 4-year plan for increasing the WRVUs for time behavioral health services, and see the first implementation of that. And also changing the supervision rules for behavioral health services and RHCs and FQHCs. Changes to the Medicare Diabetes Prevention Program. CMS keeps trying to get this one off the ground. Now they are changing how they intend to reimburse. It previously was a performance-based reimbursement, so you received payment after so many attended sessions. CMS has recognized the issue with that you don't have continual participation by individuals, and so you're not hitting those targets. They intend to now just go to a straight fee for service, attend a session and bill for it. They also intend through the end of 2027 to permit these programs to be delivered virtually, but only if you are a approved provider who has maintained their CDC in-person recognition. So it's not just open season. You still have to be able to deliver the services virtually, in person as well as virtually. Having made reference to dental and oral health services, last year CMS determined that it would begin paying for these services when they were inextricably linked to other covered services. And for 2023, that included organ transplant, cardiac valve replacement, and valvuloplasty procedures. For 2024, they intend to extend coverage to include head and neck cancers, as well as chemotherapy services, CAR T-cell therapy, and anti-restorative therapy. I should have practiced those words. So they're broadening out even beyond what they had intended in 2024. And they say, what other services are we missing? Please tell us when you have dental and oral health needs that need to be addressed as part of other services. Medicare Shared Savings Program, there's some changes to the quality reporting and performance requirements. They've changed the window for beneficiary assignment. I think the most interesting thing here is the updates to the benchmarking methodology, where they are now going to apply the same HCC risk adjustment model across all historical benchmark years and the performance year. You know, we are in the midst of moving from the 2020 HCC risk adjustment model to the 2024 risk adjustment model. It has some significant impacts on HCC weights. And so to account for that, they're making this adjustment within the MSSP, again, seeking comment on that. And finally, last but certainly not least, the quality payment program. The big frontline news here is that the threshold goes from 75 to 82 points. They continue to implement the MIPS value-based pathways and make modifications to the existing MVPs. They intend to eliminate health IT vendor category as a distinct third-party intermediary for submission of data, that those folks will not have to meet the QCDR requirements. And they also announced some changes to the public reporting procedures of QPP data. Yes, I ran through those last things very quickly. The good news is we have a solution to that. On August 9th, Kathy and I will be taking a break, a much needed and probably much anticipated break for all of you. Our colleagues, Valerie Brock, Lori Foley, Angie Caldwell, will be coming in to provide a much deeper dive on provisions of the Medicare physician fee schedule. We sort of gave you the 10,000 foot view of things. They're going to bring it down to ground level and talk in detail about the impacts of these provisions. Kathy and I will be back August 16th for the 2024 final rules, the IPPS rule primarily, we assume. And then we will then have our colleagues Karen Anderson and Tracy Waugh joining you on August 30 for an EMTALA update, particularly around enforcement activities. So thank you all for being with us for 90 minutes to review these important rules. And as Kathy and I would be remiss not to say, be sure to comment by September 11th.
I apologize for the coughing fit, but we did it.
Excellent. Thanks all.
Thanks to our presenters, Martie and Kathy. Please remember to stay on the line once the webinar disconnects to complete a short survey for CPE credit. Your CPE certificates will be emailed to you in approximately 3 to 4 weeks. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete this short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.